In the past, the radiopharmaceutical agents were typically beta emitters, which are quite good at going into the bone and treating disease, so patients did achieve a palliative effect. Unfortunately, they really were not specific, so there's a lot of bone marrow failure. And justifiably, a lot of oncologists were reluctant to use the beta emitters because there was no survival advantage, and the patients often were precluded from having additional therapies due to their bone marrow compromise. So FIGO, the radium-223, is quite different in that it's an alpha emitter, and because of that, the deposition is different. It's a calcium mimetic. It goes specifically to the parts of the bone that are affected by cancer, but it spares the bone marrow, so there's much better tolerance and there's less myelosuppression. The most important thing about this drug is that the ALSYMPCA trials show that there was a survival benefit. So not only does it relieve pain and prevent secondary skeletal events, but patients that are treated live longer. It's very important that these patients are evaluated in a multimodality clinic. A urologist, a urologic oncologist, and a radiation oncologist should review the patient's case and determine what is the appropriate therapy. We have so many different treatment options now, and the concept of therapeutic layering is so important that it's vital that these clinicians decide what the proper order is. A patient that has very bulky lymphadenopathy or visceral disease should be treated with chemotherapy. On the other hand, early on in the castrate-resistant phase, if the patient has bony involvement, that would be a patient that I would strongly consider for radium-223. This patient, it's quite logical to use radium-223. The patient has clear castrate resistance. The PSA is rising despite the fact that they were treated with androgen suppression. Once we get to that phase and there's bony involvement, we know that we have to intervene in order to improve survival. The patient had bony involvement, but the lymph nodes were either not present or less than 3 centimeters, and there was no visceral involvement. These are the patients that are most appropriate for radium-223. As a radiation oncologist, it's very important that I interact with the urologist, the urologic oncologist, and the radiologist. It's very important that we utilize the latest studies. For example, sometimes patients will have a completely normal-looking bone scan. However, the sodium fluoride PET-CT will show early involvement. That helps us identify patients early in the course that are most appropriate for therapies such as radium-223. We know from the ALSYMPCA trial that less than 70% of patients received full 6 cycles of radium-223. That's a major impact on their outcome. We know the patients that received 1 to 2 did not do as well as the patients that received the full 6 cycles. So in discussion with the urologic oncologist, I always stress the importance of identifying the patients early and supporting them through the full 6 cycles. Those are the patients that will receive the maximum clinical benefit.